Lecture objectives: to describe the normal anatomy of optic nerve and its different segments, to classify optic neuropathy and what we mean by optic neuropathy, and optic neuritis, which is part of optic neuropathy, to evaluate demyelinating optic neuritis, define and evaluate the common diseases involving the optic nerve, including disc edema, papilloedema, and optic atrophy. The optic nerve is made up of 1.2 million nerve fibers, which are efferent nerve fibers. Each one of them originate in a retinal ganglion cell. The retinal ganglion layer is one of the layers of the inner retina. It contains retinal ganglion cells from which the fibers of the optic nerve originate. So the optic nerve is a bundle of fibers. It contains no rod, no cone. That's why it's the blind spot of the eye. The optic nerve is surrounded by pia mater, which is the innermost layer. Then the subarachnoid space comes, and the arachnoid mater, and the top layer, which is the dura mater. So the optic nerve is surrounded by the same layers of the brain. That's why any elevation in intracranial pressure will cause edema of the optic nerve due to communication of the subarachnoid space of the optic nerve with that of the brain, and the CSF inside the subarachnoid space is the same as in the brain. This image shows you the fundoscopy, what we can see during ophthalmoscopy or fundus slit lamp examination, which gives you an idea about the head of the optic nerve, which is the intraocular segment, the first part of the optic nerve. We call it the head or the disc. This is the beginning of the optic nerve. The optic nerve is only sensory nerve. It contains no motor innervation, no motor function, just sensory, and it's an efferent nerve, as we said, composed of only nerve fibers. It carries information to the brain. Most of these ganglion cell fibers carried within the optic nerve synapses in the lateral geniculate body, which is the ones responsible for vision. Some of these fibers will synapse in the pretectal nuclei of the midbrain. This is the portion responsible for the pupillary reflex. So pupillary fibers are carried within the optic nerve, and vision-related fibers, each one of them will synapse at different site. As we see in this image, the optic nerve head or the optic disc is made up of well-delineated margin structure, neuroretinal rim, the orange part, and the central cup. It carries central retinal artery and vein, which, when the optic disc, as we see here, these nerves and arteries emerge from the margin of the disc and distribute to the retina. The optic nerve is made up of 4 segments. We explained the intraocular portion, which is the optic nerve head or optic disc. It's 1 millimeter depth segment and 1.5 millimeter vertical diameter. The second part is the intraorbital segment, which is about 25 to 30 millimeter in length. It began at the posterior part of the globe and end at the optic foramen, which is the opening of the optic canal. Inside the optic canal, there is the intracanalicular segment of the optic nerve, which is about 6 millimeter in length. From the posterior opening of the optic canal to the chiasm, we have the last portion, which is the intracranial portion. It varies in length, but usually about 10 millimeter. So the optic nerve begin at the optic disc and end at the chiasm. Any lesion in any location here will give us uniocular optic nerve or optic head pathology. Any lesion within the chiasm tract, radiation or cortex will give us binocular optic disc manifestation. In this image, you can see the normal anatomy of the optic nerve, the margin, which should be clear, the CD ratio, cup to disc ratio, which is the portion of the vertical diameter of the cup relative to the vertical diameter of the whole disc. It should be 0.3%, 0.2 or 0.1, no more. The portion between the optic cup and the margin of the optic disc, we call it the neuroretinal rim, which is the orange part. It should be at this particular color, orange, healthy and well discriminated. What we mean by optic neuropathy? Optic neuropathy means there's some disorder or disturbance in the optic nerve. It's either related to the optic nerve or due to underlying pathology in the retina or underlying systemic pathology. It can be divided simply into inflammatory, glucometers, ischemic, hereditary, nutritional, papilloedema, traumatic, compressive and infiltrative. The inflammatory glucometers and papilloedema are the main discussion in our lecture today. Inflammatory optic neuropathy, it's optic neuritis and neuroretinitis. Optic neuritis, it's further divided into demyelinating, para-infectious, infectious and non-infectious etiology. Demyelinating is our interest today. So inflammatory optic neuropathy is divided into either optic neuritis or neuroretinitis. The optic neuritis type is further divided into demyelinating, para-infectious, infectious and non-infectious. Etiology, glucometers, we have an idea about it, and I included some pictures for you in this lecture. Ischemic, it's either anterior or posterior ischemic optic neuropathy and divided into the non-arthritic, arthritic variety. Diabetic papillopathy is another type of ischemic optic neuropathy, which is common. Hereditary optic neuropathy is very long list of optic neuropathy. Mainly our interest is in Leber hereditary optic neuropathy. Most of the optic neuropathies, the hereditary type runs into family. It's either X-linked or autosomal dominant, and there should be some family history. Nutritional and toxic, which is related to malnutrition, to toxin exposure, to tobacco, alcohol abuse. Papilloedema, which is type of optic neuropathy only related to increased intracranial pressure, and it's usually bilateral. Traumatic, any trauma to the head or to the eye. Compressive, due to orbital lesion, tumor, mass, infection. Infiltrative, in sarcoidosis, in tumors and infective agents. We said that our interest today is about optic neuritis. Optic neuritis can be classified into demyelinating, para-infectious, infectious and non-infectious. Optic neuritis usually is the inflammatory type of optic neuropathy. There is inflammation. This inflammation either para-infectious, which is following usually viral infection or immunization vaccine. Infectious, this might be sinus related, usually chronic sinusitis, severe sinusitis, especially sphenoethmoidal, can lead to optic neuritis. Cat scratch disease, syphilis, Lyme disease, and cryptococcal meningitis and herpes zoster. These are important infectious agents that might end up with optic neuritis. Non-infectious causes like sarcoidosis, systemic autoimmune disease such as systemic lupus erythematosus, polyarthritis nodosa, and different types of vasculitis. Any of these might end up with optic neuritis. What about the demyelinating type? This is the most common cause of optic neuritis, especially in young people. This classification we spoke about is according to the underlying etiology. What about the anatomical location of involvement? We can classify optic neuritis also according to the anatomical location of involvement, or according to the ophthalmoscopic appearance. In other words, we mean the optic nerve is divided into the anterior part, which is visible through ophthalmoscopic examination. Any inflammation of this visible part through fundoscopic examination, the part that we can see during the fundus, the part I included in the images above, we call it papillitis. We can see here the inflammation as hyperemia, edema of the optic disc. Peripapillary hemorrhages. Peripapillary hemorrhages, I mean with that, they are flame-shaped type hemorrhages surrounding the optic nerve head inside the retina. Papillitis is the most common type of optic neuritis to be encountered in children. It might also affect adults, but mainly optic neuritis in a child, usually papillitis. What about the rest of the optic nerve that we cannot see through fundus examination? The retrobulbar portion behind the globe. Any inflammation in this part will result in retrobulbar neuritis. In retrobulbar neuritis, the optic disc is normal, but the rest of the optic nerve is inflamed, swollen. This is visible on MRI scan, not on fundoscopy. During fundoscopy, the optic disc is normal, so we suspect nothing, but we have certain signs that might point to the underlying pathology and give us a suspicion about involvement of the optic nerve. So we send for MRI scan. This will show us inflammation and swelling of the optic nerve, the retrobulbar portion. So retrobulbar neuritis is the most common type of optic neuritis seen in adults, and it's the most common presentation in multiple sclerosis. In multiple sclerosis, we don't see disc swelling, but there is retrobulbar neuritis. According to ophthalmoscopic appearance, we have another type of optic neuritis, which is a neuroretinitis, where there is papillitis, I mean with that inflammation of the optic disc, and macular star configuration. There is certain type of exudate, like the sun, like a star surrounding the macula. This is the least common type usually. So we know the classification of optic neuritis, which is the most common type of optic neuropathy. So optic neuritis have different pathological or etiological causes. The first one is the demyelinating optic neuritis, para-infectious optic neuritis which is related to infection, and the non-infectious type. Now we are speaking about demyelinating optic neuritis. Demyelination is a pathological process in which the myelinated nerve fibers lose their myelin sheath through phagocytosis, subsequent to which astrocyte will lay down fibrous tissue instead of myelin sheath. Fibrous tissue doesn't function like the myelin sheath. There will be disruption of nervous conduction through the central nervous system, and this will result in the clinical manifestation of multiple sclerosis in association with demyelinating optic neuritis. In demyelinating optic neuritis, we have certain symptoms and signs and expected visual field defects. As a symptom, the patient usually complains of unilateral subacute vision impairment, but the vision impairment is not very severe. I mean, visual acuity is usually in the range of 6/12, 6/18, 6/24, or 6/36. It might sometimes be very poor vision impairment, but this is rare, usually in the good range. The age ranges from 20 to 50, so it's mainly around 30. It's more common in females. What the patient describes usually a phenomena we call it phosphonis. What we mean by phosphonis, the patient usually experiences tiny white or colored flashes or sparkles, certain flashes, white flashes or sparkles experienced through their visual axis. In addition to the most important thing, which is the pain with eye movement that the patient experiences is very specific to optic neuritis and is present in over 90% of patients. Sometimes there might be associated with a frontal headache or even tenderness of the globe. The headache, the tenderness of the globe, the pain sometimes precede the visual impairment, sometimes accompanies. Other signs, these are the symptoms and relating the visual acuity decrease. What about other signs? We have certain signs of optic nerve dysfunction, which is impaired color vision, impaired contrast sensitivity, relative afferent pupillary defect. This is a type of a pupillary examination specific for optic neuritis. We call it relative afferent pupillary defect. During examination, I see that the optic nerve is normal during fundus examination, because most cases of optic neuritis usually occur in the clinical spectrum of retrobulbar neuritis. I mean with that, the disc is normal, but there is inflammation in the retrobulbar portion of optic nerve. Smaller percentage might present as actual papillitis. Papillitis means optic disc edema. Papillitis, optic disc edema are the same. Visual field defects expected here are central scotoma or diffuse depression on the central 30-degree of visual field, or let's say central scotoma. The course of optic neuritis is very important because most patients want to know what will happen next. Will they keep losing their vision? Is their vision loss is permanent, or will there be any improvement in vision? Actually, it's of good prognosis. What I mean with that it's truly that the vision loss is rapidly progressive over the course of 3 weeks, but after that, visual improvement will happen rapidly and gradually. Most vision will return in the first few months after the acute attack of optic neuritis, and the rest of vision will return slowly over the course of 6 months to 1 year. So by 1 year, we expect that 90% of patients will have good vision of 6/9 or even 6/6, and only 10% of them will have a progressive vision loss and permanent vision loss. Only 10%. 90% very good vision, 10% progressive worsening. 1 year is what we tell the patient, that by 1 year we'll have most of your vision. What about the treatment? There are certain indications to introduce steroid as a treatment. We don't give treatment for all patients. When vision within the first week of onset is worse than 6/12, when the patient is with only one eye, one seeing eye, the other eye is lost by certain pathology, and the patient has only one seeing eye, or when the vision is worse than 6/12 in the first week of onset. Treatment has a certain rule. It will speed up recovery by 2 to 3 weeks. It might delay the onset of a clinical multiple sclerosis over the short term, but the treatment will not influence the final visual outcome. What I mean with that, the final visual outcome, we said that 90% of patients will have good vision, 10% will have poor vision. This is not affected by treatment. Treatment will not affect what this patient final visual outcome will be. Most patients do not require treatment, except the cases we mentioned. Steroid regime will be intravenous and not oral. Intravenous methylprednisolone, sodium saxonate 1 gram daily for 3 days, followed by oral prednisolone for 11 days. The dose we give it usually 1 milligram for each kilogram of the patient weight, and we taper it slowly over 3 days. So we start with intravenous 3 days, we complete it by oral. This is important. We never give oral steroid only in optic neuritis. Why? Because oral prednisolone might increase the risk of recurrence of optic neuritis, and it will not give us any protection against multiple sclerosis. So intravenous steroid might delay the onset of a clinical multiple sclerosis over the short term, so it's important. This is picture of optic disc edema or papillitis. Papillitis is the same as disc edema. There is a swelling of the visible portion of the optic nerve. We see the disc margin is not clear. You can go up to the images in the beginning of our lecture and you see that the optic disc usually presents itself with a clear disc margin, clear cup, normal blood vessels. Here we see there is a blurring of the disc margin and there is no visible cup. The blood vessels also are tortuous and blurred. In severe cases, we might have even hemorrhages around the optic disc, so don't be surprised. Disc edema due to elevated intracranial pressure, on the other hand, we call it papilloedema. So disc edema is not a specific term, might refer to any underlying cause of disc swelling, including papilloedema. But when we say papilloedema, there must be elevated intracranial pressure. Whenever we see this picture in a patient, this patient needs thorough neurological investigation to exclude intracranial tumor. Usually the patient with the papilloedema present as with the clinical picture of transient visual obscuration, which is a type of transient visual loss. Usually the vision loss lasts for 30 seconds and return. There is no other pathology of the optic nerve that results in this type of transient vision loss, just in elevated intracranial pressure, in addition to the clinical picture of headache, nausea, and visually the patient usually also present with horizontal diplopia, double vision, due to 6-nerve palsy. 6-nerve palsy is non-specific neurological sign that present whenever there is elevated intracranial pressure due to stretching of the abducent 6th cranial nerve over the peteris bone. So these are the clinical visual significant signs, which is transient vision obscuration and 6th nerve palsy, that are associated with increased intracranial pressure in addition to papilloedema. So when we ask you about the visual manifestation of elevated intracranial pressure, you mention these. What happens in glaucoma? This is a type of optic neuropathy. Glucometers, optic neuropathy. You see enlargement of the diameter of the cup relative to the diameter of the disc. Here the diameter of the cup is about 0.8 or 0.9 from the diameter of the disc. This is advanced optic disc damage due to glaucoma. As this image illustrates you how to measure the CD ratio. In the first image, this is normal CD ratio, it's about 0.2. On the second image, we see 0.7 CD ratio and almost total cup 0.9 CD ratio in advanced glaucoma. Different types of visual field defects are expected with different types of optic neuropathy. Central scotoma and enlarged blind spot are the most common. Central scotoma occur with demyelinating optic neuropathy, with compressive optic neuropathy, with toxic and nutritional optic neuropathy. Sometimes toxic and nutritional optic neuropathy might result in central cecal scotoma also. Hereditary optic neuropathy, on the other hand, also might present with centrocecal scotoma, while papilloedema cause enlarged blind spot. Disc pallor or optic atrophy. Disc pallor is a description for optic atrophy. This is late stage changes that occur to the optic nerve, result in these manifestational difference and disturbance from the normal disc, in addition to visual disturbance and permanent vision loss. So optic atrophy results in manifestation, change of the optic nerve, and permanent loss of vision. Disc pallor or optic atrophy is the late stage of many retinal pathologies and many optic disc pathologies. In other words, optic atrophy usually results from axonal degeneration from the retina to lateral geniculate body. So any area between the retina and lateral geniculate body undergo axonal degeneration of the nerve fibers of optic nerve will end up with optic atrophy. Beyond lateral geniculate body, no optic atrophy will happen. Just between the retina and lateral geniculate body. Optic atrophy is either primary, secondary, or consecutive. Primary optic atrophy, which is visible in this picture, you see the manifestation here is disc pallor, pale disc. I can't recognize the cup. I can't recognize the orange neuroretinal rim. The disc margin is clear here. There is no gliosis. Gliosis, I mean additional fibrous tissue that grow around the blood vessels emerging from the optic nerve. The optic nerve is flat, pale, well demarcated margin without any detail, flat, chalky white disc, just like the chalk طباشير. This is a primary optic atrophy. It happens when the pathology in the posterior part to the globe, to the lateral geniculate body. Any area from the retrolaminar, we call the disc posterior to the optic cup, which is the head of the optic disc. Any portion behind the optic cup, we call it the retrolaminar optic disc. So any pathology involving the area from retrolaminar disc to the lateral geniculate body will cause primary optic atrophy. What I mean with that, there is no optic disc swelling. The disc, the head of the optic nerve, did not have any previous swelling. The pathology in the posterior parts. So when optic atrophy occurs in this condition, it will be primary type optic atrophy, and it will have this picture: clear disc margin, chalky white disc, no fibrosis, no gliosis, no cup, and no visible neuroretinal rim, and the disc will be flat. The second type of optic atrophy is the secondary type. Secondary optic atrophy occurs when there is antecedent or previous swelling of the head of optic nerve, unlike the primary one where the pathology behind the optic nerve head in the retrolaminar portion. Here the optic nerve head is inflamed for multiple reasons. Could be chronic papilloedema, anterior ischemic optic neuropathy, or optic disc papillitis. Any of these, if it happens, it will end up later on by secondary type of optic atrophy. We see here two images: primary optic atrophy versus secondary optic atrophy. You see the difference. In primary optic atrophy, it's a flat white disc with a clearly delineated margin, while in secondary optic atrophy, the margin is not very well delineated, the disc is not flat, and it has a gray dirty color with some fibrosis and gliosis around the disc, which is the whitish indiscriminated border lesions. This is fibrosis. So this is secondary optic atrophy. This means the optic disc head or the optic disc is inflamed previously by either chronic papilloedema, papillitis, or anterior ischemic optic neuropathy. While in a primary optic atrophy, the underlying pathology could be retrobulbar neuritis, which is a manifestation of multiple sclerosis, could be compressive optic neuropathy, could be traumatic or nutritional and toxic, could be hereditary. So each one of them has certain pathology you need to know. So as we said here, the primary optic atrophy due to pathology in the retrolaminar portion, and the secondary optic atrophy due to pathology in the optic nerve head, the disc. What about consecutive? Consecutive optic atrophy occurs due to retinal pathology surrounding retina, like in retinitis pigmentosa, which is a pathology of the inner retina, like after central retinal artery occlusion, or vasculitis of the retina. A type of optic atrophy emerge, which we call it consecutive optic atrophy. The picture of consecutive usually sometimes similar to secondary. It's dirty gray, poorly delineated margin with visible retinal pathology. I see retinal pathology with optic atrophy, so I consider it consecutive and not secondary. This image of retinitis pigmentosa, we see there is a pigmentary disturbance of the retina with attenuation of the blood vessels emerging from the disc. I almost can't see any blood vessels except for the temporal arcade, superior and inferior, and it's very limited. In addition to optic atrophy, this type of optic atrophy here, we call it a consecutive optic atrophy.